Good Thursday evening, good Thursday evening, good Thursday evening on this March the 11th, 2021. March the 11th, 2021. My panelists and moderator, if you like, you can go ahead and get to your social media and share if you like, if you have those capabilities, all well and good. In the meantime, again, this is a wonderful Thursday evening, and we are delighted to have a session dealing with the correlation of the heart and the kidneys. The Health and Wellness Ministry, all parishioners, and I, pastor of New Hope African Methodist Episcopal Church in Hoschton, Georgia, are glad for your virtual presence. So this evening session, the correlation of the kidneys and heart, our virtual guest moderator will be nurse and author Danita Clark. The guest panelists are Dr. Tara Robowski, cardiologist out of the great state of Florida, nurse LaTesia Branham out of Thomasville, Georgia, nurse and senior pastor Sonja King-Harris out of Ellaville, Georgia is where her church, but Columbus area. And also we have Dr. Sharica Brookins, nephrologist out of the area of the Augusta, Columbia area, Augusta, Georgia, Columbia, South Carolina area. Now, according to National Kidney Foundation, under the Heart and Kidney Connection section website, your heart and kidneys are two important organs in your body. They work together to keep you healthy, just like a relationship, whether it's family or whether it's a business relationship. When one is affected, the other is too. In other words, your heart can affect the health of your kidneys, and your kidneys can affect the health of your heart. Yes, it is World Kidney Day, but my focus is not only on my parishioners at New Hope that I serve, but every individual kidney and heart across the globe are communicating effectively. Now, before I hand this off to Nurse Clark, our moderator, I'd like to go around and just quickly get a quick introduction from our distinguished guests on this evening. So first, I'm going to start with Dr. Hrobowski. And if you could you just tell us a little bit about yourself, please?
Hello, everyone. I am Dr. Tara Robowski. I am a board-certified advanced heart failure and transplant cardiologist here in Largo, Florida. I actually moved here about a year ago from Atlanta. So I was in Atlanta at Piedmont Heart Institute for about 5 years before coming to Florida. I always tell people, you know, I'm the cardiologist that other cardiologists send their patients to when they've kind of, you know, run out of options for them, I guess you could say. So unfortunately, you know, I'm a very nice lady, but I hope that none of you all will ever need any of you all or any of your loved ones would ever need my help. But yeah, so I'm happy to be here tonight. Thank you for having me.
Awesome, awesome. So glad to have you. The next we will have is nurse and senior pastor of a wonderful church in the Muskogee County area, Pastor Nurse Sonja King-Harris.
Hello, everyone. My name is Sonja King-Harris. I'm a pastor and I'm also a registered nurse. I've been in nursing. It's been 27 years. I started out basically just doing dialysis, in-center dialysis, and now specialized in peritoneal dialysis and also home hemodialysis. And not only that, I'm also a pastor, and I pastor in Ellaville, Georgia. My church there is Union Hill, but basically I'm here in Columbus, Georgia. My nursing is here in Columbus, Georgia. And so hopefully I'll be able to give you guys a few tips or something that'll be able to help you when it comes to renal disease and also a nurse perspective from it, along with a pastor's perspective.
All right.
And thanks so much for having me. Thanks for having me today.
Most definitely, most definitely. Thank you so much. Dr. Sharica Brookins.
Hello, everyone, and thank you for having me as well on this great day of World Kidney Day. I am a board-certified nephrologist and internist in Augusta, Georgia. I work at the local VA here, but I'm also the founder and CEO of Remote Renal Care, which is a solely telemedicine kidney practice that I started to mainly target the rural people in Georgia who need kidney care. So I am glad to be on here and to provide my insight on the relationship between the kidneys and the heart.
Wonderful. And you're also, I think you're the only one, you're also a member of Alpha Kappa Alpha Sorority Incorporated. So, amen. Also we have Nurse Branham, Nurse LaTesia Branham, in the great city of Thomasville, Georgia, Thomas County. And so please tell us about yourself. Apparently you might be on mute or you're not coming through.
How about now, Pastor?
Wonderful.
Okay. I apologize. Good evening. I'm LaTesia Branham, and I'm from Thomasville, Georgia. I am a registered nurse, and I've been a nurse for about 12 years. 11 of those years, I have been in dialysis, in-center, acute, and I'm currently doing PD and home hemodialysis. Currently with DaVita, and I am excited to be here with you all, and thank you, Pastor Sands, for having me.
You're more than welcome. And last but not least is our wonderful, distinguished moderator, nurse and author, Danita Clark. So Nurse Clark, could you tell us about yourself, please?
Hi, you guys. So I'm Donita, and I've been a nurse for about 15 years. I've been in healthcare for about 25 years, so I've done everyone's job except for you lovely doctors. I've been a CNA, a phlebotomist, an LPN, and a RN now, and then now I'm a nurse manager. My specialty is cardiology. I love advanced heart failure. Not that I love it for my patients, but I do love the specialty. And so I worked at several different cardiology units, from step down to transplant to just basic telemetry. But cardiology is definitely my passion. So I'm super excited to talk to you guys about all this. And thank you, Pastor, for having us.
Oh, sure, more than welcome. And so I'm going to turn this over. I know we may get a chance to touch on a little bit about the bell curve with the heart rate and the fraction and all of that, and the sodium and the electrolytes and then the renal issue with the creatinine and all of that. Because here's the deal. We want to educate people to let them know what types of tests that they are in need of when they go to their primary care as well as their specialist. It is very, very important. A lot of people don't even look at those results and look at those tests, and I think that that's very important. Okay, I'm gonna be quiet. I'm gonna let Nurse Clark hand it off to her. Thank you.
Okay, so one of the questions I know people don't typically understand is, what is the function of each organ? So my two doctors, I want each of you to kind of just break it down in layman's terms and tell us what the function is of the organ. So we'll start with you, Dr. Hrobowski.
So I always consider, everybody in their specialty always thinks that their organ is actually the most important, right? But think about it, right? So the heart is really kind of like the mainframe, right? Because you can actually not have a brain and the heart still beats, right? And it can still, that's how I get organs for donation, right? Or suitable organs for donation, because the person is quote unquote brain dead, but the heart is pumping and supplying blood and nutrients and everything to every other organ, right? So I consider it the mainframe. And so when it says, it's the center of the circulatory system, I mean, it's just that. So the heart pumps, right? That's the contraction, pumps blood out to all of your organs, right? It sends blood to the organs take up the oxygen, and then it goes back to the heart, the right side of the heart, so that it then goes through the lungs, oxygenates, the blood, sends it back out to the rest of the body. So I would explain the heart as just that, just the mainframe, and honestly, what keeps every other organ alive. And I'm sure Dr. Brookins can attest to that, right? No heart, no kidneys, right?
Right.
Go ahead.
Okay, and so just as we know, the heart is important. The kidney has a few key roles, but I will start with one by saying it is one of the main detoxifying organs within our body. So every time that heart pumps, 25% of your blood is going to go straight to the kidney. And the kidney is constantly cleaning the blood, and all of the toxins and things that your body does not need is turned into urine, and therefore it is emptied out into the toilet. So your kidneys do this constantly all day, takes all of your blood and cleanses it. Now, the kidneys are also important in managing your blood pressure. So one thing that, as a nephrologist and a hypertensive specialist, is patients who are not diet control or have difficulty with medications, there are conditions that can originate from the kidney that can contribute to high blood pressure, but the kidney plays a key role in managing blood pressure. The kidneys also play a key role in your red blood cell production, as well as your bone health, and most importantly, balancing electrolytes. So the kidney serves a few key roles, but one in particular is definitely serving to detox our bodies.
Can one of you explain to me just a little bit broader of what she said about the electrolytes? What are electrolytes and what is the normal range?
Well, there are a wide variety of electrolytes, and just like the term says, like elect, and then the lights part, they're molecules that have like an electrical capability to them, and they serve different functions throughout our body. So whether it be with our muscles, so your muscles in your arms and your legs, your muscle in your heart, various activities throughout your gut, whether it be brain activity, so nerve activity. So they serve a different function throughout the body. So one in particular would be potassium. Another one would be magnesium, sodium, chloride. So there are a wide variety of electrolytes, and pretty much the kidney serves to filter and whatever we eat in our diet that we need to hold on to, it makes sure it stays in the blood and it doesn't come out into the urine. And it depends on the electrolyte, the range of what's considered normal.
Dr. Hrobowski, what does the term heart failure actually mean?
See, now you're talking my language. So heart failure it's a complex clinical syndrome that occurs when there's been injury to the heart, okay? And so when there's injury to the heart, what happens is it's like your body goes into this fight or flight kind of activation. And in the short term, that's great, right? Because that's what keeps you standing on your feet, right? And keeps you running, right? But in the long term, the processes that occur actually become deleterious and ends up leading to cell death and heart failure, okay? And so more specifically, or in simpler terms, when we describe, so as a cardiologist, when I tell a patient, you have heart failure, I'm speaking of two things: either the issues with the actual pumping function of the heart, so that's called systolic heart failure. So that means the contraction of the heart is weak. So instead of giving a full contraction like this, their heart may be pumping like this, okay? But then there's a different kind of heart failure that all of us, you know, if God blesses us to live long enough, we'll all end up with the second kind of heart failure. That's called diastolic heart failure. That's where the issue is not with this pumping function, it's with the filling function, okay? So I always tell my patients with this second kind of heart failure, imagine your heart is made out of concrete. It's like a balloon that's made out of concrete versus rubber, right? Like a regular balloon. When you pour water into a regular balloon, what does it do? It expands to accommodate the water that you poured into it, right? Well, imagine that same balloon being made out of concrete. If you pour that same amount of water in there, what's gonna happen? It's not gonna fill up. The water's gonna backflow, okay? And how that backflow manifests, you know, on our body is, you've seen patients with swelling in their legs, right? You've seen patients who get, you know, really bloated. They tend to retain fluid here, you know, in their bellies. Sometimes they can't lie down flat. That just means that that backup of fluid has actually backed up into their lungs. And that's what's giving them that sensation that they can't breathe when they try to lie down flat. And so that's just because the heart, you know, our joints get stiff as we age. Well, so do the muscles in our heart. It gets stiff as well. So that's the second kind of heart failure. But they're gonna, honestly, the symptoms are exactly the same, and some of the management is the same. It's just that with the kind of heart failure where the pumping function is weak and I can't get that pumping function back, then those are the patients that then I have to start considering for heart transplantation or artificial heart pumps. The kind of heart failure where the heart is stiff, the treatment options are exactly what Dr. Brookins does. She controls the blood pressure. She's, you know, making sure their diabetes, you know, is controlled, or at least, you know, sending them to someone who can help them do that. You're controlling all of the other comorbidities that they may have, controlling their sleep apnea, because we don't transplant hearts for that second, you know, kind of heart failure, only for the kind of heart failure where the pumping function is weak.
Thank you. So Dr. Brookins, what do you see when a patient is exhibiting those heart failure symptoms? What do you see in your patients?
Okay, I actually had a patient before I left work. I was called in the ICU. So as Dr. Hrobowski is saying, that heart, when it's not really pumping, normally, as I stated earlier, the kidney should get 25% of the blood every time it pumps. So if you have a heart that's only pumping at a 10% capacity or a 20% capacity, we're getting less blood to kind of provide to the kidney so that it can do its job. And so that's what we tend to see patients can go into kidney failure, because the kidney is shocked that it's not getting the blood supply that it needs to function and actually do its job. And so once it's shocked, it's therefore not able to detoxify the body. So toxins can build up. It's not able to correctly balance those electrolytes. So we will tend to see potassium levels increase, or we will tend to see acid levels increase. And if we cannot manage these things medically, that's when dialysis becomes an option. We can also, once again, I don't think I mentioned, but the kidney is also important with balancing fluid within your body. So if someone is in a state of heart failure and subsequently enter into a state of kidney failure, they're not able to get rid of the fluids that they need. And as Dr. Hrobowski stated, they can have a larger abdomen or fluid on their body, and then it tends to compromise their breathing, to prevent them from being put on a ventilator. We then offer dialysis. So we can tend to see the kidneys fail as a consequence of the heart failing.
Pastor King Harris, so your patient comes in and your patient now is a new dialysis patient. How do you educate them on the process? And tell us a little bit about what dialysis does.
Okay, so most of the patients, whenever the patients come in, we will educate them on the different types of dialysis that we have. And we have what we call in-center hemodialysis. And that's what a lot of people are familiar with. They're familiar with people coming into the center 3 times a week. It may either be like Monday, Wednesday, and Friday, or either a Tuesday, Thursday, and Saturday. And they will actually come into the facility where they will actually have the teammates to actually put them on a dialysis machine, and they will do dialysis on them for those 3 days. Another option that we offer is what we call peritoneal dialysis. And the peritoneal dialysis is basically a dialysis where an individual will have, it's like a tube, it's like a tube with small holes on the end that goes into the abdomen area, the peritoneum area. And with that type of dialysis, individuals can do this type of dialysis at home. Most people, depending on whatever the doctor's order is, but most people will have to do this type of dialysis every night. But once again, it depends on what their prescription is and whatever the doctor's prescription is. But this is a type of dialysis where they will actually come to the nurse will train them. On the average, most people may train about 7 to 10 days, where they can actually come to the facility, they can train by themselves, or if they want a family member or a caregiver to train with them, they can actually have that individual that can also train, and they're able to do this type of dialysis at home. They are still responsible for coming into the facility for lab draw and also coming into the facility to be able to see the nephrologist. And we also have what we call our third type of dialysis, is what is called home hemodialysis. And home hemo is basically, they're doing home hemo, they're doing dialysis at home, but they're doing the hemo where they're actually putting needles in their arms, and they're actually trained on how to do that. And that is a little more extensive. They offer a variety where they can actually train with a partner. That's the one that's recommended. And also, depending on what area that you may be in, they do actually have some people that do solo hemodialysis. So those are some of the things, just some of the options that they have available.
Okay. Nurse LaTesia, so your patient needs some nutritional education. What can I avoid, or what should I avoid? You know, if my kidneys are not working too well, what would you educate your patients on?
First and foremost, you always want to encourage them to watch the sodium intake. They should avoid no more than about 2,000 milligrams a day, with in each meal about 200 milligrams is preferable. And also encourage them to take in about no more than about 32 ounces within 1 day. Now, depending on what type of dialysis they do, their fluid intake kind of changes, because those that do peritoneal dialysis are able to remove more fluid daily versus in center, which is 3 days a week. You'll also find that some of the dialysis patients have issues with their phosphorus level. In center dialysis patients or hemodialysis patients have a harder time removing phosphorus from their blood. So they have to stay away from foods such as frozen foods. You also want to stay away from your dairy products. All of those have lots of phosphorus in them. And then you also talk about your potassium. Your potassium, as the doctors were telling us, our kidneys do not remove potassium when they are not functioning properly. So those that do in center, they have a harder time, once again, removing potassium because they only have dialysis 3 days a week. Now, those that are doing peritoneal dialysis, because they do it every night, they sometimes will suffer with their potassium level being too low, and we may have to encourage them to intake more potassium.
Thank you.
So the modality is very important.
Okay. Dr. Hrobowski, tell me about the fluid intake. My feet are swollen. I keep taking my water pill, but I just can't get the swelling down.
So honestly, that is one of really a very poor prognostic indicator, meaning that may be telling you and your physician, your cardiologist, your nephrologist, that it's time that you, especially if you have the kind of heart failure where the pumping function is weak, that it may be time to visit an advanced heart failure cardiologist, and that you may need to be considered for some surgical options to help correct your heart failure. Because unfortunately, when you have advanced heart failure, it leads to what's called cardiorenal syndrome, kind of what Dr. Brookins was kind of alluding to earlier. Unfortunately, again, if your heart is so weak that it's not pumping blood to the kidneys, you're not going to be able to get that fluid off. And then there's a different kind of issue. You're so fluid overloaded, right? You're so congested with fluid that, again, you're not perfusing your kidneys well. So it's kind of two different mechanisms. One where you're not pushing the blood there, you know, your heart isn't pushing the blood there. And then the second kind is where the blood may be trying to get there, but it's so congested already. Your kidneys are so congested already that, again, it's still leading to the same outcome, that you're not getting adequate blood flow or filtration with the kidneys. So you're going to continue to retain fluid. So unfortunately, if that's occurring, then it's probably time for you to see an advanced heart failure cardiologist. Because at that point, you could continue to beat your kidneys to death with diuretics, but all that, it's not going to work at that point.
Thank you. Dr. Brookins, tell me about my high blood pressure and kidney issues. How do they correlate with each other?
So within the kidney, there are like sensors. So almost like if you have a remote control to your car and you press a button to tell your doors to unlock, or you tell your car to start. Well, there are sensors that are within the kidneys, and the sensors can determine, well, if the blood pressure is too low, let the kidney will make these adjustments to pick the blood pressure up. So the kidneys will retain more of salt, therefore to retain more water to help plump up the blood vessels and increase the blood pressure. If the blood pressure is too high, then the kidney senses, well, wait a minute, this blood pressure is too high. Let me get rid of salt, therefore get rid of fluid. So when we think about blood pressure, the main thing to think about is salt and water, which is why those are the key things in our diet to manage not only our weight and our fluid balance, but also our blood pressure. So there's pretty much a sensor within the kidney that determines, is the blood pressure too high, is the blood pressure too low? And that's also why I tell a lot of my patients where it's mostly diet related high blood pressure is, if you cut back your salt, I promise I can get you off of some of these medicines. If we can cut back your salt, we can cut back your fluid intake, we can very likely take you down from 4 pills to maybe even 2, to maybe even 0, but you have to work with me. So salt intake and fluid intake are very important when it comes to blood pressure management, and diabetes being the #1 cause of kidney disease, and high blood pressure is the #2 cause of kidney disease.
How does diabetes affect my kidneys?
So diabetes, it's kind of similar to high blood pressure in that it affects the blood vessels within the kidney. So diabetes has been known to have an effect on the best way I can describe this is, within the kidney, we have 1 million engines. That's how many we're born with. Over 2 million engines, 1 in each kidney. Well, just naturally, as you get older, you tend to lose some of those engines. And if you've ever heard, and I think we're going to get into this, how do you know you have kidney disease? If you've ever heard of an EGFR, I explain to my patients that contributes to your EGFR. The more engines you have, the higher your EGFR. So just naturally, as you age, you can lose some of those engines. But when you have uncontrolled conditions like diabetes and high blood pressure, you tend to lose more and more of those engines. And these are conditions where it's not reversible. So we tend to see that diabetes can affect the actual engines within the kidney, which are pretty much those balls of blood vessels that we call a glomerulus. And so the high blood pressure attacks that, as well as the diabetes attacks that as well. So controlling those tends to kind of slow down the loss of our engines to kind of preserve our kidney function over time.
Thank you. So I like that you said we were about to get into that. So today, as you all know, is the 1-year anniversary since WHO announced that we were in a global pandemic. What have you guys seen with COVID in relation to your patient populations? Have you seen an influx? Have you seen an increased mortality? What has just been your personal experiences? I'll start with you, Dr. Hrobowski.
So, yes. So unfortunately, there's a new phenomenon called COVID cardiomyopathy. And so unfortunately, COVID can wreak havoc pretty much on every, organ system because of the way it enters the cell. So each cell, just about every cell that we have, whether it's the cells in our lungs, the cells on our heart, things like that, has that ACE2 receptor. And that's how the COVID virus binds onto that ACE2 receptor, and that's how it enters into the cell and affects that particular organ system. So unfortunately, the virus can directly invade the myocardium, or the muscle of the heart. And unfortunately, when it does that, it can lead to scar development, or it leads to inflammation, and then that inflammation ultimately leads to a scar. Well, we all know scar is not functional tissue, right? And so that leads to, remember we talked about that decrease in pumping function, right? Mm-hmm. Because you need to have all of the muscle in your heart or in your myocardium in order to get a full contraction. And so unfortunately, when COVID scars the myocardium, it leads to decreased pumping function. So it can lead to, like I said, the cardiomyopathy. It can also lead to inflammation on the membrane that actually surrounds the heart, that we call pericarditis. It can lead to what's called stress-induced cardiomyopathy. So I've actually been seeing a lot of that. And I don't know if it's, there really is no known mechanism behind this kind of stress-induced cardiomyopathy, other than, being in a global pandemic is a stressful situation. So again, you can have that fight or flight system kind of be activated very acutely, and the heart just gets stunned. And then it does not pump properly. The good thing about that kind of heart failure or cardiomyopathy is that with time, with medications, that typically reverses and you can get that pumping function back. One of the other things that I've seen a lot of is patients presenting with, we touched a little bit earlier about electrolytes, right? I've seen, especially the younger patients that have presented with COVID, at least to my hospital, they have come in with what we call ventricular tachycardia, or sudden cardiac death, where they had this funny, crazy heart rhythm that led to pretty much them dying. Luckily they were able to be revived, but it was because those electrolytes were out of whack. The potassium was low, the magnesium was low. And so as Dr. Brookins mentioned before, electrolytes, in that word is electric. And so those electrolytes actually affect the electricity of the heart. And so if those electrolytes are out of whack, then that can lead to the electricity in the heart being out of whack and leading to the sudden cardiac death. So you've seen on TV, where they run in with the crash car, they have the pedals that shock, the patient and that kind of thing. So that's actually what COVID has led to a lot of the times in our younger patients. Luckily, the few that I've had, it's, a young body can withstand a lot of things. So luckily those particular patients survived, but there were a slew of young-ish patients, the 50-year-olds, early 60-year-olds that unfortunately succumbed to COVID because it didn't just affect one thing. COVID is 100% a multi-organ, disease, because it does affect the kidneys. By affecting the kidneys, it did affect those electrolytes. By affecting those electrolytes, it did lead to that sudden cardiac death. So yeah, unfortunately, we were affected very heavily by COVID.
And for kidney patients, kidney disease itself is a chronic inflammatory disease, which is why kidney disease is listed as one of the key risk factors for those who we're encouraging to get vaccinated. But what I have seen with kidney patients that make it to the ICU, they're not making it out of the ICU. Mm-hmm. And so, especially not just my dialysis patients, but my non-dialysis patients with kidney disease, if they're getting to the point to where they're intubated, unfortunately, they're not making it out of the ICU. What we do know is for those who are diagnosed with COVID that are hospitalized, but not in an intensive care level, those individuals we are seeing return home. And we are seeing some patients have a worsening in their kidney function. Some are having improvement back to where they were prior to their COVID diagnosis, and some are not. I would definitely like to share a quick story about a young patient that I have, who I'm still seeing. He had a later stage of kidney disease. He developed contracted SARS-CoV-2, and he was asymptomatic. So he had no idea that he had contracted the virus. And all of a sudden, he started having this symptom of where he was just constantly going to the restroom a lot. And so he wasn't scheduled to see me for like some months. And he's like, no, Dr. Brookins, I think I need to see you sooner. So we had him come in, and he started spilling a lot of protein in his urine. So one way I like to describe the way the kidney works, which I didn't do to the audience, is I describe the kidney also, it's that those engines as like a coffee filter. So when you have your coffee filter and you put the ground coffee there, and then you put the water, you get coffee that comes out, but the ground coffee stays in the filter. Well, diseases like diabetes more so, and high blood pressure can do it. They can poke holes into this coffee filter. And so now when you put in your water, you're going to get some of the coffee grounds into your cup. So that's kind of how it is. In this case, the water is the blood, and instead the protein should stay within this coffee filter, but protein is leaking out. So this young gentleman, who is African American, he developed a lot of protein in his urine. And when he was biopsied, there was a large suspicion that COVID had affected his kidneys, and he's now in the later stages, and we're actually working him up for a transplant and preparing him for dialysis. He's only 37. And the more unfortunate thing about it is he was diagnosed with a genetic condition that we are seeing more often in our African American patients. And so we are tending to test more. Unfortunately, there's no treatment for it, but it's called APOL1. He was diagnosed with that. And a lot of the biopsies we're seeing in the kidney world are Blacks with this condition that's spilling a lot of protein, and with the APOL1. Whenever they develop COVID, that COVID is like the light switch that turns on the worsening of their kidney disease. So it's very important. I know we're not here to talk about COVID, but it's very important for us to bring awareness to how it can affect the kidneys and why vaccination is so important. But I'm like I said, I'm seeing people not come out of the ICU. I'm seeing people come out, and then I'm seeing people who are asymptomatic now progress to almost needing dialysis. So it's a gamut.
So I just moved back from California last month, and I was managing an ICU, and every patient that we intubated, unfortunately, they expired. The only patients that came out, I had 2 patients that survived, and neither of them were intubated. So every patient that I had that was intubated, unfortunately, did pass away. They were young. They weren't all elderly patients either. So COVID has definitely impacted us in a great way. And it's taught us a lot of life lessons. But what would you guys say? I'm going in for my annual checkup. They always draw blood. They take so much blood every time they go in, right? What are you checking for? What should I be asking the doctor to check? What should I be worried about?
I'm going to be as brief as I am with my patients. There are 3 key things that you want to know from your primary care. It starts with your primary care. Number 1, you want to know what is your eGFR. If your eGFR is less than 60%, we strongly encourage patients to be referred to a nephrologist. If you have blood in your urine, we encourage you to be referred to a nephrologist. And if you have protein in your urine. So those are the 3 key things. Do I have protein in my urine? Do I have blood in my urine? And what's my eGFR? The eGFR is from the blood tests, and then the protein and blood are going to come from your urine test. So those are 2 key important tests. Now, during this month, I actually, I like to do a campaign every year for Kidney Awareness Month. And this year it's called Urine Luck. It's a play on the word. But one of the things I like to stress to patients is simply just looking at your urine, you can learn a lot about what's going on with your body before we can with a test, a blood test and a urine test. So I strongly like to promote and educate people on what your urine should look like and what it shouldn't look like.
What should it look like?
Well, it should look like a normal straw color. If it's bubbly, that's not good. If it's pink, that's not good. If it's a dark orange, these are all indicators of different conditions. If it's cloudy, those are the main things I tell people. If it's cloudy, you could have an infection. If it's bubbly, that's the protein. That filter is leaky, something's punching holes in it. If it's a dark orange, that could be liver problems, could be dehydration, could be medications. And I also like to tell people clear urine is not always good. Clear urine could be a sign of just drinking too much water. Kidneys are really smart. The kidneys know what you need, what you don't need, it's going to get rid of it.
Thank you.
Was I supposed to answer that question too?
Yeah. What do I need to have all this blood drawn for? What are we checking for?
Honestly, I think the bulk of the information, at least from y'all know I'm biased, but I think a lot of the information is gonna come before you even get to blood tests, and I got this little quick story because it's a very personal story. My husband's gonna kill me, but I get a phone call. I'm in the doctor's lounge. I get a phone call from my husband, and they're like, "Oh, they sent me away from the dentist," and I'm like, "How did you get kicked out of the dentist's office? Like, that's weird." My blood pressure was 220 over 106. Now I'm just like, come on, like, you're married to a cardiologist. I don't get it, right? So I'm like, come to my hospital, like, just come to the hospital. Like, I'm freaking, I mean, and this is why you don't treat your family, right? This is why Dr. Brookins is very, I'm sure, all the nurses, this is why you don't, there's rules against, having family members as patients and things like that. So he gets there and we're talking with, I asked one of my colleagues to see him right away. And he goes, "Well, so nobody ever told you had high blood pressure?" He goes, "Well," and I'm like, wait, hold on. No. Because then I look like the bad wife, right? So, but this is the thing. So 2 years ago, he had high blood pressure and nobody did anything about it. That is a problem. That is called the fancy word is clinical inertia. And it happens all too often with Black people. So I think before you even get to a blood test, if you notice anything, don't let somebody say, "Oh no, you can fix that." No, he didn't fix it though. He didn't fix it. This is 2-3 years later, and my husband could have had a stroke. You understand what I'm saying? So even before we even get to a blood test, right then and there, I know you may not know the exact number of what, a normal blood pressure should be, but 160, 170 ain't it, and that's what his was, 2 years ago. And that's how it progressed to being, 220, now. So I think even before we get to blood tests, we need to make sure we're asking all the questions. And if they're saying something is abnormal, like the blood pressure, you have the right to ask about that. And you have the right to say, no, I think, this may need to be treated. And if somebody's trying to poo-poo you away, great, thank you for this visit, I'm gonna go elsewhere. So that's my 2 cents. In terms of labs, I agree with Dr. Brookins. You definitely want to know what your GFR is. Again, like from a cardiologist, I mean, the creatinine, of course, that's as she knows, that's a measure of kidney function as well. Probably not as specific as eGFR, but also lipid panel for a cardiologist. You want to make sure what your lipid panel is, and hemoglobin A1c. So hemoglobin A1c is the number that we get to, we can diagnose diabetes, of course, but it's really more so of a measure to see if you have diabetes, how well you've been controlling it over kind of like a 3-month period. So I would say the hemoglobin A1c, lipid panel, so that's your cholesterol, things like that. One other thing that I think oftentimes goes unnoticed and can be actually a cause of heart failure, and that's thyroid function. So I always check thyroid function tests, because unfortunately, if you have uncontrolled or untreated thyroid disease, that can decrease the effectiveness of your diuretics. So if you're trying to lose fluid with let's say the Lasix or whatever diuretic Dr. Brookins is giving you, and you're noticing that it's not really working, you may have a thyroid issue, And, putting, of course, all the pieces together, it won't just be out of the blue that you got a thyroid issue. You'll have other symptoms too, but that's just something to kind of consider, because that's something easy to fix. So that's my 2 cents.
Nurse LaTesia, can you just tell me what a normal blood pressure is and what a normal heart rate is?
So for a normal blood pressure, it does within kidney failure. They usually try to stay less than 140/90. However, I do educate my patients individually on their normal based on what their nephrologist has educated them or tried to target. But for someone who is not in kidney failure, or someone who is not very aware of what their blood pressure is, and they go to Publix and they may want to take it there, they want to see something less than 140/90. Now, books will say 120/80 as well, but that is kind of rare that you see that. When you get in that 140/90 range, that's when, we're worried that something may be going on. So it is just kind of individual on the history and how much the patient knows about themselves.
Pastor Kings Harris, I'm sorry. Can you tell me, so when you go to dialysis, do they just stick the catheter in your skin? How do you do dialysis?
Well, basically for the patients that do in-center, if they're doing in-center dialysis, they will either have where they have to have 2 needles placed into their arm. One is arterial, one is venous. And it will either be what they call a fistula or either a graft. Okay, so those individuals, they will come in and the staff will place 2 needles in their arm. If they are a home patient, if they do home hemo, that means that the patient will either be cannulating themselves at home, or either a caregiver will be cannulating themselves at home. And for the ones that do peritoneal dialysis, they do not have to deal with needles at all. All they have to do is actually hook their connections up to a fluid. And so it doesn't deal directly with blood.
Can I make a comment on peritoneal dialysis? Because peritoneal dialysis is the way to go.
Yes, yes.
The problem is my people We get diagnosed so later stages of kidney disease to where peritoneal is not an option. Number two, I noticed that with most patients, when they are good candidates, and I give them that as an option, they shy away from the independence or the, I don't want to say accountability, but they just prefer just going into the center, being there 3 days a week. No, I'd rather just sit down and then go home.
Mhm.
Peritoneal dialysis patients do so much better. And so I just really want to stress to people, the sooner you can see anyone regarding your kidney function and diagnosed and managed, you can be evaluated to be a PD candidate, because you can be so later in your kidney stages where you're not a peritoneal dialysis candidate. But it is definitely, you know, the better of the three options of dialysis. And then I wanted to make one last point. I said EGFR, but I do want to bring awareness to EGFR is discriminatory against African Americans.
Mhm.
And when I say know your EGFR, that's just something to at least know your ballpark of where you are in. But I myself and others in the nephrology community have kind of backed away from using EGFR so much because it can be discriminatory against Blacks when it comes to determining what their kidney function is, because it's race-based. And we've seen that it's not always the best. It can affect them when it comes to being evaluated for a transplant. It can also affect them when it becomes the moment to determine the dose of medicines to put them on. So I said EGFR, but I do want to make a point that it is it's very big in our news world, the nephrology news world, about how racial discriminatory it is.
And
I
I
just wanted to
a little
add
blurb on there on the labs. Most often that I've seen that it says if you are African American, you know, and it tells you that it's discriminatory.
But it's one of those things where it's what we had, we rolled with what we had.
Mhm.
That was it until someone blew the horn and said, listen, we have to stop using this.
I'm sorry, Pastor.
I was just going to say, I just wanted to back up on what the doctors were saying earlier. When you notice that something is going on different with your body, I have someone that I've actually been following, and I want to say it's been over 20 years now, but they were referred to a nephrologist because they simply was spilling urine. They just did the simple urine when they tell you to urinate in the cup at the doctor's office, and it had protein in it. And so the doctor just kind of repeated it, and the doctor said, well, maybe we just need to send you to a nephrologist. And this patient was actually sent to a nephrologist, and it has been over 20 years, and this individual is not on dialysis this day. And the nephrologist was really happy that the primary care had referred him, because he was actually had been diagnosed with, I think it was glomerulonephritis. He was diagnosed with that, and it's been over 20 years, and this person is not on dialysis. So just because they say you need to go to a nephrologist, it doesn't necessarily mean that they're about to put you on dialysis, that there are things that they can do to prevent certain diseases that can prevent you from actually starting on dialysis. But it's important for you to follow up. You know, if they say you need to see a nephrologist, if they say you need to see a cardiologist, we want to try to encourage you as individuals to follow up, because it can prevent certain things within your life. And for this individual, they're simply because the nephrologist said that they were so excited, because if they was continued the rate that they were going, that they would have been on dialysis, and it's been over 20 years.
Wow.
I think that goes back to, you make an excellent point, because I think it goes right back to the statement that Dr. Brookins was making in terms of a lot of us, we allow things to happen to us instead of taking ownership. Because that way I feel like if something goes wrong, then it's easier to be like, you did it. You know, it wasn't me, you know, I didn't do this to myself. You know what I mean? So it's that sense of, it's the sense of ownership. And luckily that person took ownership and said, well, you know what, I'm going to follow up with this nephrologist, and ended up, it pretty much saved his life. Wouldn't you say, Dr. Brook? I mean, definitely added to his life by not ending up on, you know, dialysis, of course, which has, you know, increased mortality and morbidity, right? And so I think the same, you know, goes for cardiologists. You know, no, I'm not the funnest person necessarily, you know, to come and see. You know, I think, you know, I have a little fun in my office, but there are also people that I've recovered their heart pumping function. So coming to me, you know, actually wasn't all that bad, you know? So we have so many different things. There's so much, you know, new evidence-based medicine coming out, so many new things coming out that even if it's just to learn what's new, it's worth, you know, visiting that specialist. You know what I mean? I'm the specialist. So I'm not trying to get more heart failure patients. Like, I'm really not. You know, especially when they start looking like me and they ended up being younger than me. That's when and I'm sure you guys, when they start becoming younger than you, you're like, whoa, okay, we gotta, something has to change. So I think, you know, it's just education. And I think it also goes to when people walk in that door and they see somebody that looks like themselves.
Right.
I think there's a lot to say for that as well. In terms of, well, maybe I will go back. Maybe, you know, she looks hip. She looks, you know, like she's, you know, had some good times in her life, you know, so she understands, you know, I don't want an ICD right here. You know, I don't want to cut right here. You know, maybe she can understand that there's certain things that I still want to be able to do. And then you model your treatment plan around everybody's goals. But I think when they start seeing more people that look like themselves, they may be a lot more comfortable in going to that person.
That's one of the biggest things. I had a 30-year-old patient who was diagnosed with COVID, but when he went in, his blood pressure was like your patient's 200s over 100s, right?
That's not my patient, that's my husband.
I know, I was trying to be nice.
Oh, okay.
And so, you know, I had spoken to him in regards to, you know, going to see a cardiologist and getting on some blood pressure medications. And his wife had also spoken to him, who was also a nurse. And we went over, you know, it can cause stroke, it can lead to this. And it didn't hit him until we started talking about the intimacy issue.
Boom.
Yeah.
And that's the only thing that would register to him in the importance of controlling your hypertension. So how do we educate African-American, our brown brothers and sisters in regards to, you know, diet modification, living a healthy lifestyle, just getting to the doctor?
You gotta meet people where they are. You have to meet people where they are. Unfortunately, you know, we still, it's 2021, we still have food deserts. That's crazy. I lived in Detroit. I did my general cardiology and advanced heart failure and transplant training in Detroit at Henry Ford Heart and Vascular Institute. And I had to drive 10 miles to get ground chicken. It's just ground chicken, y'all. It's not, I mean, it's not fancy. You know what I mean? So I think we have to meet people where they are. Some people can't afford, we all know, we've been to Whole Foods, got half a bag of groceries and it was $55.
Right.
That doesn't work for everybody. That's not going to work for everybody. Even, you know, when it comes to prescribing medications, I know what the evidence is. I know that I should be prescribing Entresto as first line, right, Dr. Brookins? But everybody can't afford Entresto. So I need to find what's on that $4 list at Walmart or what's free at Publix.
Right.
So I think that we just need to make sure that you know, we need to go back and remember when we were broke, like I was in, you know, in fellowship, before we all had a little money, you know? So I just think if we stay cognizant, and I think that's what keeps people coming back to, when they know that you can relate. Now, I haven't always been in this, you know what I mean, in nice things, that kind of thing. I remember when, you know, I lived on a fixed income and that was all I had.
Mm-hmm.
So I think, again, it's just about meeting people where they are.
True.
And I like to add, that's why renal dietitians play a very important role in the dialysis unit and in the kidney clinic, because I can, you know, I do try my best to take my time with patients to go over, okay, well, this is how you can manage your phosphorus, this is how you can manage your potassium. But the renal dietitian has an abundance of resources to maybe even help direct patients to programs that will help in subsidizing food. I used to volunteer because of COVID. The program did not happen in 2020, but in 2019, we had a program here in Augusta, Georgia, and it was called Fruit and Veggies Prescription. Mm-hmm. And so those who were lower income, what they would do is they would come once a month, and they would have to get their measurements, their blood pressure, and then they would also go to weekly cooking classes. Now, of course, at these cooking classes, whatever they made, it was enough portion for them to take home to their families. And at the end of all of this, every month, they got SNAP coins, and they were able to go to one of our local farmers markets and take those coins and trade it in for fresh fruits and veggies. So we have that here in our Harrisburg community in Augusta, Georgia. But, you know, I know a couple hours away in the rural community like Waynesboro, we don't have those programs. But I do know that nutritionists and social workers are very key when it comes to kidney patients, because they can help facilitate them with the necessary resources, because diet is so important when it comes to kidney disease. It's so important.
So I don't have any health insurance. Can you guys tell me where I could go in your community to actually get a checkup?
Well, we have that clinic in particular during the day. It operates as a low-income clinic. Okay. But once again, with COVID, you know, no one's pretty much functioning because these clinics operate off of state-funded monies. Besides the ER, that's like the primary care for a lot of, you know, underprivileged individuals. And it's unfortunate that because of the lack of health insurance or difficulty with getting health insurance, even for those who, you know, once had jobs and now they've lost their jobs, the emergency room has become their primary care. So, but that's generally how, you know, if someone doesn't have insurance, that's their only option. But even then, how are they going to be seen on a continuous basis, you know, in my clinic or, you know, in Dr. Hrobowski's clinic? Or when it comes to dialysis, one thing I do make patients aware of is once you are on dialysis for at least 3 months, you automatically qualify for Medicare. And so that tends to cover your dialysis treatments. But prior to that, we tend with our undocumented individuals, they have to come to the emergency room to get their dialysis because they cannot get into a dialysis facility because they're undocumented. So what they do is they come to the emergency room maybe once a week. And we know what they're there for. Yeah. Dialyze them and you send them out.
That's a shame. It's 2020 and like that's a shame.
It is. It is.
That's a shame. But I think we also need to make sure that we're taking advantage of our resources. Right. And if if you're admitted to the hospital, then it's my understanding, I think you get I think you have to get a follow-up appointment. And so at least, at least for the DRG of heart failure, you have to, get a follow-up appointment within 7 to 10 days. So we fortunately have a wonderful financial coordinator who has helped so many of my patients obtain, whether it's one of the Obamacare plans, those kind of things. But unfortunately, that's because she cares. You know what I mean? Like, this is somebody that actually cares. And well, whether she did or not, I was going to ask her to do it, and she worked for me. So, so it's that kind of situation where you almost got to get connected with the right people. And that sounds, unfortunate, but there are people that are willing to help, and unfortunately, they may just have to do their due diligence in finding a clinic that will help, that has a financial coordinator that will help them apply for certain things,
Can I add there that our religious institutions in Augusta have been very pivotal when it comes to those who are uninsured with getting care. So when I first started here in private practice, there's a Christian organization here, and what they would do is, under I guess some sort of funding and resources that they have, they're able to refer their patients to private doctors' offices and provide some of the coverage for them. And also so I did most of my training in Nashville, the majority of my training in Nashville, and the Tennessee Kidney Foundation, I would volunteer with them. And some of the local churches, when they would have their health fairs, we would go there and do blood pressure and urine checks. So right then and there, we would check you for protein. We mostly did the protein in the urine and the blood pressure. And if you registered high on those, then we gave you some sort of receipt that you would then take to the Matthew Walker Center, which was the center that pretty much cared for those who were uninsured. So in some cities, they do have, certain things in place, but churches play a very important role in the African-American community when it comes to that.
True. And here in Columbus, we have certain places that will offer different types of benefits. We have Mercy Med here in Columbus, and they do assist patients that may be having difficulty as far as trying to get appointments, and also assistance with medication. So there are some resources that are available, but they are limited in this area.
Thank you, ladies. Pastor Sands, did you want to add anything?
No, you all, I tell you, have covered a lot, and I really tell you that you can have 3 novels with you all's great piece of information, great nuggets. What I trust, before I go any further though, let me do this. Let me digress back. Sister Fonzie Walker, I'm gonna have her to bring greetings. She's one of our parishioners at New Hope, and then I will make some other comments. Sister Fonzie Walker.
Yes, Pastor. Good evening, everyone.
Good evening.
Good evening. We greet you in love this evening on behalf of our pastor, Reverend Timothy Sands, and family, and the New Hope AME Church family of Hoschton, Georgia. We are so delighted to have you this evening. We give special thanks to our moderator, the nurse, Danita Clark, and nurse. And on the panelists, we have nurse/pastor Sonja King-Harris. Thanks so much. Dr. Tara Robowski, we thank you so much. Nurse LaTesia Branham, we thank you so much. And Dr. Sharica, we thank you so much. I'm just enjoying it. I'm learning a lot of what's going on. As being a diabetic myself, and you really educate me on a lot of stuff, and we appreciate it. Thank you, and please come back again.
Thank you.
All right, thank you so much, Sister Walker. But yeah, just real quickly, I trust that those that are not dealing with having to deal with defibrillators and pacemakers, as well as going on dialysis. I trust everyone, those that are not, will be able to steer clear of that. But now again, I don't want to get a frowny face from my doctors, because I know that is some additional revenue as well. But again, we trust that everyone will be able to stay away and don't have to go up to those different tiers of drugs, tier 1, tier 2, and tier 3. But what I try to always do in my ministry, when I started out, even prior to being a pastor, my concern was always people's health and wellness. And that's very, very important. And so, again, you all have brought valuable information, not only to the church, but to the global community, those that are listening now, and those that will listen and view later. And so we just can't say thank you enough for taking your time out of your evening to be with us. And we're appreciative. So again, thank you, thank you, thank you. And thank you, our moderator, Nurse Clark. Much appreciative to you, because she is working on some more novels, and as well as nursing. So continue on the fight. And we appreciate Nurse Branham. We appreciate you, Pastor King Harris. In the AME Church, we have annual conferences. So with her being a nurse and then being a full-time pastor, we just want to say thank you as well.
Thank you.
Yes, and also Dr. Brookins and Dr. Hrobowski. We are much, much appreciative of your time. I'm going to ask Brother Walker to close us out in prayer, and we will go from there. Brother Walker.
All right. Father God, thank you for this day. Father God, bless Pastor Fans and his family. Father God, bless everyone that is online. Bless the sick and shut in. Father God, bless the ones that are in hospitals and nursing homes. Father God, give them strength to go day by day. Father God, bless the government. Father God, bless the nation. In Jesus' name, amen, amen, amen.
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 Again, thanks to each and every one of you. We are much appreciative. Does anybody have any other comments? My panelists and moderator, I'm sorry. Anybody else have any other comments? I'm sorry.
I have one.
Yes.
No, go ahead.
I do have one, and I like to share this with people. It is something coming from the Bible, and it's coming from the Amplified version of the Bible. Proverbs 18:9. I'm gonna just read the second half of that. It says, "He who does not use his endeavors to heal himself is a brother to him who commits suicide." Let me read that again. He who does not use his endeavors to heal himself is brother to him who commits suicide. So we have given some endeavors for people to heal themselves. And so it is important for us to take advantage of it. And I just wanted to share that.
Amen.
Amen. Amen.
Dr.
And
Brookins?
I just wanted to share that I know how important our culture regarding African Americans, how important our culture is to us, and especially rich in our foods. But I definitely just strongly encourage, I just always encourage moderation. And a lot of this stuff, I know you alluded to us not, this affecting business, but I'm able to make sure I don't have patients. So, so that's important to know, that a lot of the complications that we suffer from as a culture, come from what we eat.
True.
Absolutely. Absolutely. Anybody?
They're really
else?
good.
Nurse Clark, I'm sorry, I stepped on you.
I was just going to talk about the food, because we do it a lot for our traditional holidays. It's full of sugar and sodium. Those ham hock and neck bones and pig feet. No, it's not too good for you. But it's a hard habit to break, but it's not hard and smart, and it's definitely not kidney healthy.
I think one thing that I want to stress, and I think I touched on it before, is that you have to be your biggest advocate. You know, don't be afraid to ask questions. If you don't feel comfortable, you know, speaking with the position you have, then go get a new one. You know, you wouldn't let somebody, you know, jack up your hair, right? So
True.
you're not gonna let somebody jack up your hair. You definitely shouldn't let them jack up your health. You know, so it's just the kind of situation where, you know, it's okay to ask, it's okay to get second opinions. You're not, you know, at least for me, and I'm sure Dr. Brookins and anyone else on the line, if you go for a second opinion, that's not offending me because I know what I'm telling you is right. So you will be back, but you know, so it's okay. It's okay to get confirmation because sometimes hearing this news is overwhelming. To hear even the words heart failure sounds crazy, you know? So it's okay. Again, it's okay to be your best advocate. So.
And I service all of Georgia. So if, like Dr. Hrobowski said, if you're not confident in your current provider, or if they may not be sure what's going on with your kidneys, I am just a click away. I work throughout the entire state of Georgia. Remote renal.
Yeah.
That's it.
For sure.
All right. That sounds great. And once again, also for those of you who are out in global land who have not taken the vaccine, I encourage you to take it. I've taken my first dose, take my next one on Saturday, and I'm still here. So I encourage you to go ahead and take it when the opportunity arises, and go ahead and take it. For that, again, thanks to each and every one of you. I appreciate it. I love you all. Have a wonderful evening and take care.
Thank you.
Bye.
Have a good night, ladies.
Bye-bye.
Good night, Pastor.
Bye-bye.
Good night.
Bye.